Welcome. Thank you for joining us this morning. My name is Jim Connolly. I'm the president and CEO of Ellis Medicine, and I want to introduce some individuals who are going to be joining me this morning to announce this very special program. First, Dr. John Bennett, who is the president and CEO of CDPHP. Wendy Rocher, vice president for clinical services at Ellis Medicine. Dr. Robert Docks, the Vice Chair, Department of Emergency Medicine at Ellis. Marty Killian, the Director of the Pharmacy at Ellis Medicine. Mike Pascarella, Manager of the Pharmacy at Ellis Medicine. And Rachel Weber and Andrew Kufal, Emergency Department Pharmacists at Ellis Medicine. Today, we are here to announce a partnership between Ellis Medicine and CDPHP that will help make the care we deliver safer and of a higher quality at a time when our community needs it most. 2 years ago, Ellis implemented a program that would place a full-time pharmacist in the emergency department. We found there was a need for the pharmacy to have a presence in the ER because of the often unpredictable, urgent patient needs we see in the ED. This program aims to reduce medication errors and improve safety for all of our emergency patients who come through our doors. We are on a mission to reinvent healthcare. Reinvention is only made possible through partnerships such as the one that we enjoy between Ellis and CDPHP. Dr. John Bennett and CDPHP's commitment to providing high-quality healthcare to our community is illustrated by their support of the Emergency Department Pharmacist Program. I would like to invite Dr. John Bennett to speak with us. John?
Thank you, Jim. As a physician-founded health plan, patient safety and quality are our top priority at CDPHP so that we can serve our members and our community better. Ellis Medicine has developed many innovative programs and services that greatly benefit the community, and CDPHP is proud to continue to partner with Ellis Medicine in these efforts. Multiple studies have shown that medical errors have been greatly reduced in emergency departments that have added in-house pharmacists, which is what we are supporting Ellis Medicine doing. This not only helps prevent life-threatening complications and drug interactions and keeping patients safe, it also improves communication. And we've learned that improved communication around care coordination and transitions of care are essential to ultimately lead to higher quality and lower costs. The success of the weekday emergency department pharmacist program is really proof positive that this expansion into the busier weekends is paramount to Ellis's continued commitment to the safety and well-being of their patients and our community. With the addition of this weekend emergency department pharmacist, Ellis will continue to provide superior care in a coordinated fashion that they are known for. And CDPHP is really thrilled to be part of this continued support of Ellis Medicine in its efforts to really transform healthcare right here in our community. So we're very, very pleased to be part of this. Thank you.
One of the individuals who can best speak to the tremendous innovation in our community and how we provide emergency care is Dr. Robert Docks, who is Vice Chair of Emergency Care at Ellis Medicine. So, Dr. Docks, if you will come up and share some comments. Thank you.
Thank you, Mr. Conley and Dr. Bennett. I want to truly express our gratitude for the Emergency Department Pharmacist Program. Too often, patients arrive in our emergency department without all their medication and patient medical history. In these situations, we need our physician and nurses treat these patients, and having the most accurate information is obviously very important to have in a timely manner. This information helps us make decisions in how we care for our patients. Having a pharmacist dedicated to the emergency department helps us receive the information we need and enabling us to provide safer, more efficient care when members of our community need it most. The extension to having a pharmacist dedicated to the emergency department on weekends allow us to continue to ensure that we safely provide medication during one of the department's busiest times. The summer is upon us, and the summer is one of our most busy times in the emergency department. So we're really grateful to have our program now and expanding into the summer. The man behind the scenes making this all happen for us, the department, is our clinical pharmacist manager, Mike Pascarella. So I'd like to introduce Mike to give us the details.
Thank you to Mr. Connolly, Dr. Bennett, and Dr. Dox for all the support that they've given us. Several years ago, there were national patient safety standards that were implemented across the country that required hospitals to implement a process to better capture a patient's medication history. It sounds simple enough, but Ellis Hospital, as did most institutions at that time, realized just how difficult this was, especially at a time when medication and therapies and were becoming more and more complex. So about 4 years ago, we implemented a pilot study in the emergency room with the use of some pharmacy students. And what we gleaned from that study was that there was a real need for improving how we manage medications and how we captured that information in the department, in the emergency department. Physicians often need accurate medication history at a moment's notice. This history cannot be restricted to just prescription medication, but must also include many of the over-the-counter medications as well. So without physical presence there, it was becoming increasingly difficult to catch these potential discrepancies associated with medications. The goal of the program was to have a pharmacist on site in the emergency department to assist with reviewing the patient's known medication history, which we often refer to as medication reconciliation. They're also there to review medication orders and to facilitate communication between the pharmacy and the emergency room at all times. Since the program was implemented on the weekdays, 99% of patients seen by the emergency department pharmacist had a complete medical and medication history at the time they were admitted to the hospital. Now, with the support of CDPHP, we can extend this program to one of our busiest times, the weekends. This grant shows the tremendous impact that collaboration can have in healthcare. The individuals that can speak to this impact of having a pharmacy in the department the best are the pharmacists themselves, Dr. Rachel Weber and Andrea Kufo, and they will share their success and how being on site helps them prevent complications and improve efficiency with medications. Thank you. Andrea?
Thanks, Mike. Thanks. Thank you, Mike, and thank you to Mr. Connolly and Dr. Bennett and Dr. Dox for having us here today. So as Mike was saying, one of the things Andrea and I do is we talk to patients about their home medications and we try to make a list of what they're taking at home. This sometimes is very difficult because we found that patients usually do not have an up-to-date list of medications that they're taking. Oftentimes, patients are missing medications on their home list, or there's medications listed that they're actually not taking at home. Upon further talking to the patient, we usually find out they're not taking their medications at the correct time of the day, and usually they don't actually know what they're taking certain medications for. If a patient doesn't have an up-to-date list, we usually make a list for them so they can carry it with them. This is especially important when a patient gets admitted to the hospital because the admitting physician needs to know what they're on at home. They need to know what they've been taking so they can determine which meds to continue and which ones they need to modify.
Like Rachel touched on, one category of medication error that we find very frequently is improper use of medication. This includes maintenance inhalers that they're using as an on-needed basis instead of continue using it to prevent asthma attacks. Taking certain medications at the incorrect time of day, such as Synthroid, proton pump inhibitors, their cholesterol medications, and also discontinuing maintenance medications that they should continue on, like hypertension medications and cholesterol medications, or just simply taking two medications in the same class of drugs, not realizing that they were supposed to discontinue one while starting the other one.
Just to give a couple examples, one of the things Andrea mentioned is patients sometimes don't know they're supposed to stay on this medication. We had a patient recently that was diagnosed with atrial fibrillation. He was started on a new blood thinner pill, was sent home from the ER, came back a few weeks later with chest pain. And when I went in to talk to the patient, I found out that he stopped the medication. He had no clue why he was on it and that he even was supposed to continue on it. So I contacted his cardiologist to make him aware of the situation and educated the patient and his wife that this is a medication you were supposed to stay on. We had another patient that unfortunately couldn't tolerate any medications by mouth. She had a PEG tube, so all of her medications her mom crushed and administered via the PEG tube. And when I was going through her home medications, there were about 5 medications on the list that were available in a liquid form. So I just made the mom aware that the next time she went to her primary care physician, to get a prescription for the liquid form, and it was much easier for the mom actually to administer those medications at home. The patient did come back to the ER a few weeks ago, and I followed up with the mom. How did that go? And she said it was really helpful to not have to crush all those extra pills. So just little things like that, that helps the patients tremendously.
Right, and a few weeks ago, I actually had a patient that came to the emergency department with abdominal pain. She had a history of liver dysfunction, and the abdominal pain had been going on for a couple weeks, and at home she had taken about twice the maximum daily dose of ibuprofen to help with the pain. She didn't let the physician know this at time of the interview with him, and so I let him know, and luckily there wasn't any harm done for taking it at such a high dose. But my going over with her, taking too much of that medication, what it could do to her, was able to prevent any further problems happening in the future, being that she already had underlying health issues. We didn't want to give her any more problems with any GI bleeds or anything like that. So just the simple, yes, there wasn't anything that we found at this time, but it prevented any harm done in the future. And another patient, again, going back to patients not taking their medications in a proper manner, this patient had very high blood pressure in the past, so much so that she was getting some nosebleeds, was on blood pressure medication, nosebleeds stopped, she started feeling better, so she thought, I don't need to take my blood pressure medication anymore. Fast forward to about 2 weeks ago, about 6 months after she stopped taking her blood pressure medication, and she was being readmitted to the hospital under cardiology because her blood pressure had skyrocketed again. She was having difficulty breathing and some chest pains. She had stated to the nurse the medication she should have been on, but didn't say that she was taking them. So when the cardiologist went over her medications, he had bumped up her doses, and but without realizing she hadn't been taking these doses, so he had to adjust her medications to make sure she didn't have to stay in the hospital longer because her blood pressure went too low at that point. So this again, just shows the small little interactions that we do have with these patients. Luckily nothing happened, but we do prevent a lot of potential harm to people while they're staying with us.
Usually the patients are very happy there's an extra person kind of talking to them about their medications. They appreciate the extra help.
Yeah, absolutely. They definitely express a lot of gratitude that we're there, and very impressed that there's a pharmacist in the emergency department. They don't see that, so they really do appreciate it.
So thank you to Dr. Bennett for allowing us to expand our program and giving us the opportunity to talk to everybody today. Thank you, Mr.
Thank you.
Thank you.
Thank you, Rachel and Andrea, for all the great work you do in our emergency department, and thank you, Dr. Bennett, and all the folks at CDPHP for their generous commitment to this program to improve patient safety. So this is where I get to kind of ad-lib here a little bit. Over the last, 20 years, there's been this tremendous proliferation of medications, and they become so specialized in their application and their efficacy, and I think it's very, very difficult, challenging to the physicians to understand all the medications, much less the patients. And that's where we see the problem. And we all have stories like my mother-in-law, who, God bless her, is 89 and decides that today her stomach's a little upset, so she's not going to take that big pill today. She'll take 2 of them tomorrow. Or who says to me from time to time, Jim, when can I stop taking all these medications? The population does not understand that in order to control their chronic illness, they have to stay on the medications and they have to take them correctly. And frequently they don't understand how to do that. And as a result, when we are in partnership with CDPHP in so many different initiatives, and one of these, the most important of which, is to try to help manage people's care in the community so that they stay well and stay in their homes. But we can't get to everybody, and we know that there are going to be people going to show up in our emergency room, and one of the major factors in their being there is that they have been able to control their chronic illness through good medication management. And having these resources in our ER, I think, not only keeps people out of the hospital, that can be taken care of in their home, but I think it clearly improves the quality of health for people long-term and does help save lives. So, John, thank you again for everything that CDPHP is doing to support this initiative in our ER, but also in the community. And again, thank you to Andrea and Rachel for the fine work that they're doing, not just in doing it in the ER, but also spreading the word about these programs. So, and with that, I guess